Hello, everybody, and welcome to our today's webinar organized by the European Society of Contraception and Reproductive Health. We call it ESC. And our today's topic will be, as you have heard already, contraception in COVID time. So actually, I want to welcome everybody and to say that this is our first webinar and there will be much more, and the next one will be planned in September, and during the following 12 months we will have quite some webinars. So you will see in the end of next presentations also our website if you don't know it yet, so you can follow all these forthcoming announcements about the future events. So first of all, thanks to everyone for joining us today. And I have heard that we are almost 1,000 registered participants. I don't know exactly now what are the last numbers. And also many thanks to Exeltis for their unrestricted educational grant to support this our today's activity. So, my name is Kai Haldre. I'm a gynecologist from Estonia and I work in East Tallinn Central Hospital, and my mainly work is with infertility patients actually. And why I am here, somewhere behind the screen, unfortunately, I have served the last 8 years in ESC and in the ESC Executive Committee in our organization, and currently I serve as Secretary General. So I hope maybe we will succeed to fix all these technical problems, but we can continue, of course, without those as well. So first of all, some housekeeping issues. So during this next two presentations of today, you are all welcomed to send your questions. You see somewhere your questions button, so please write your questions there, and in the end of the event we will try to answer as many as possible. This webinar will be accessible during 1 month in ESC and Exeltis websites after today's event. So our planned timing for today is actually 1 hour, but of course we don't know yet how many questions there will be. I hope that there will be a lot, and then maybe we will exceed a little bit this 1 hour. We try to answer as many as possible. So just to begin, I want to remind us, and it is of course evident, that during these recent times, we all, as professionals and as citizens, we have been affected by COVID-19 pandemic. And why we are here together, it's that unfortunately, in many cases, national and local lockdowns have affected sexual and reproductive health services and sometimes also supplies. And we have noticed that in many times it has been forgotten that these two things are essential and can be, what is very important, can be life-saving. I want to remind you that in ESC, we have collected and produced a lot of relevant and updated information about sexual health issues during this COVID-19 pandemic. And you will find all this information in our webpage. It is very easy. If you open our webpage, there is immediately a button to COVID-19 Resource Center, and you are really welcome to update all your knowledge and to search for new information. And additionally, I would like in this today's context to tell you that last year, our organization, European Society of Contraception and Reproductive Health, has issued a so-called Madrid Declaration. This is a declaration of sexual and reproductive health and rights in Europe. So this is very good document, very detailed. And I hope that this can serve as a very good guidance for many countries and many specialists to follow, and very good guidance or a tool even to negotiate the local policymakers, because sometimes this is the main thing what has to be done. So to come to today's program, this is my pleasure to introduce you all today's our faculty. So first of all, we have Dr. Ali Kubba from London, from UK, and he will talk about challenges in reproductive health and contraception in COVID time. After Ali's talk, we have the other presenter, Dr. Teresa Bombas from Portugal, from Coimbra, and her talk will be about innovation, a new estrogen-free contraceptive pill. After these two talks, approximately one talk will be maybe around 25 minutes, 30 minutes, we will have the session of questions and answers. So the idea is so that you send your question, I will read it and ask our good lecturers, our good faculty members to answer them. So just a couple of words about Ali, and he can introduce himself as well. But Ali is currently Vice President of the European Society of Contraception and Reproductive Health. And every day he works as consultant medical gynecologist and sexual and reproductive health specialist in London. So Ali, not the floor, but the screen is yours now, if you know which button to press. So I hope you see it.
I will try. So I'm going to try to share my slides. Let me just see if I can share my slides. Okay, I think everyone can see the slides now. I hope someone sends a confirmation. So I'm going to proceed, and it is my great pleasure to be involved in this webinar. And can I say good morning, good afternoon, good evening, because this is a global webinar and we have people from all over the world. On my slide, you can see Big Ben. The reason why it's there is because I work at St. Thomas's Hospital, which is just at the end of this bridge called Westminster Bridge, which I'm going to show you again. So I work very central in London. My hospital is part of King's College London, and we're talking about women's health. So this is a painting done by one of my cousins called Leila Kubba, who's an artist from Iraq, where I come from, and it shows mother and baby. This is my declaration of interest, and the contents of this presentation has not been influenced by the supporting company. We are really grateful for the unrestricted education grant from Exeltis. It's a partnership that we appreciate, and we are very grateful for this opportunity. This is my agenda, but before I come to the agenda, I'm showing you two slides to really, for all of us to appreciate and say thank you and acknowledge the work of the healthcare heroes of this world. And you can see there is a view that in Time magazine, we already have the person of the year 6 months ahead. I'm going to talk a bit about educating the public, because I know that some of the countries who are taking part in this webinar are still at the peak of the corona infection. We in the UK have moved on into a sort of the second phase, the recovery phase, and I thought I'll share a couple of slides on that. And then I will talk about why women have done better in relation to COVID-19. We will show two slides on pregnancy and COVID, and then we'll talk about services and contraception. And of course, women did much better in this crisis. As the captions here says, is where women lead, the virus recedes, and we have 3 countries which have done so well: Germany, New Zealand, and Denmark. There's also Iceland and Finland and Taiwan. So my message is to sort of leave women in charge of public health messages. I'm going to show you these 3 slides just out of interest, what we did in the UK. So the first slide on the left is the bridge I just showed you, Westminster Bridge. And this is the message about stay at home. This is when we were in lockdown in the UK, and you can see this bridge is one of the most busy bridges in London, and in lockdown, there is not a single car or bicycle or anybody on it. St. Thomas's Hospital, where I work, is just at the end of the bridge, as you can see it. It's just in front of this round building. The buses are obviously to carry essential workers. The second message is social distancing, and the British are very good at queuing, and you can see we're 2 meters apart. You can see the arrow on the ground, so we move this way, then that way, then that way. This is a supermarket, and you can see the circle on this figure. We put it there because this is Theresa May. This is the ex-Prime Minister of Britain, and she's waiting in line 2 meters apart to get her shopping. And obviously, washing our hands and sanitizing is very important. I thought I'll show you this last slide, because a lot of people say, well, this is very lonely if you stay on your own as social distancing. And you can see in this slide, this is where I live. So my house is just sort of somewhere about 10 minutes walk here. So this is where I come on the River Thames, and you can see people in clusters, but social distancing. So there's a group here, there's a group here, there's a group there. So that is something that, a message that you can put to your population. The second point about lockdown and quarantine is that we need to look after ourselves, and we have to obviously watch our weight, exercise, though we are stuck at home. A lot of people suffer from anxiety and depression. It's very important that they know where they can ask for help, and help is available. And I think if you're locked down with your partner, it is time really to know your partner better and possibly have a second honeymoon. But the more serious message here is this is a poster which is in Arabic from my home country, which addresses the issue of intimate partner violence. WHO calculates that this has been occurring in about 30% of cases. It's very serious. We had cases here in the UK, cases in other parts of the world. And the message that I wanted to give you is, obviously, if you have someone living with an abusive partner, they need to access help. And one of the tips in the UK is to designate what we call a numerical helpline. So if a woman thinks that she is at risk and wants to call for help, she will ring the emergency line. So for us is 999. But then she has to talk on the phone, and of course her partner is there, so that may not be possible. So the thing that happened in the UK is that people who are at risk of intimate partner violence have been given an extra number. So you do 999, and then you do 123, and then close your phone. The person receiving your call would know that you are at risk of intimate partner violence. This is just a tip. Now, why do we think women had a lower risk of getting COVID-19 and of having poor outcomes? Well, I think there is possibly a behavioral factor, because women are more likely to stay at home. They're less risk-taking. They're less impulsive in their behavior. They probably smoke less, drink less, and have better health profile. Biologically, we think estrogen enhances epithelial, endothelial, and collagen function. Therefore, it may help your arteries and other parts of the body. Estrogen is an immune modulator, and we don't know whether that works in a positive or a negative way as far as COVID is concerned. Androgens have been linked to greater severity of COVID infections, and it could be that because obviously in a woman, though there is testosterone, it's less than the androgens in men. And biologically, a mother wants to protect her children, and therefore probably follows the instructions better. Some of these slides I might go very fast in, but they will be available for at least a month, both on the ESC web and also with Exeltis. So let's look at pregnancy and COVID. This is one slide. It's pretty complex and busy, but this is from the UK, what is called UCOS. UCOS is a database from the Royal College of Obstetrician Gynecologists in the UK and Oxford University, and it is building to become one of the important databases on women with COVID infections. So what does it tell us? It tells us that the infection risk for pregnant women is the same as non-pregnant women. Now, I'm aware that the CDC this week in the US, in the USA, have actually published data to suggest this may not be right, but this is the UK experience, and it is based on a fairly accurate record. The CDC essentially cannot differentiate between hospital admissions for COVID only or hospital admission for obstetric problems. Severity of the disease, the risk of dying are no different from non-pregnancy, but the third trimester is a risky time. So COVID in women in the third trimester could be more severe, and there is an associated higher risk of prem labor. This is from Wuhan, and intrauterine deaths. This is from New York. There is definitely no increase in the miscarriage risk or congenital abnormalities. You have to remember that there are risks associated with poor outcomes. So women who are diabetic, hypertensive, have COPD, have coronary artery disease, cancer, severe asthma, cystic fibrosis, all at a higher risk. And I here mention sickle cell disease because that predisposes women carriers, especially if they're homozygotic, to infection, and obviously older age. Vertical transmission, it's been said that it doesn't happen. Well, in this study, and I'm going to show you one in a minute, vertical transmission does happen, but it is rare and does not seem to have an adverse outcome on the fetus. We know the placenta is negative for the virus. So in the UCOS study, and this is 427 cases, which were about 6 weeks ago, so it's being updated as we speak, 2.5% of the babies tested positive. And if the mother is COVID positive, 5.6. But there was no increase in admission to the neonatal intensive care unit. In the same study, 5 women died, and this is lower than the standard maternal mortality. Cesarean section rate was higher, and I'm not going to expand too much on it. This is important, breastfeeding. Breast milk is negative for the virus, and if infected, the mother can feed, but she can wear a mask, and the baby can actually have a face shield during breastfeeding. The other option is that the woman can express the milk, sterilize it, and give it to the baby. This is another busy study. I don't want you to get too concerned about it. This was really, really recent. This was published 2 weeks ago in the British Journal of Obstetrics and Gynecology. And I want to just highlight the conclusion. This is about the outcome of the neonates. So the conclusion was that neonatal COVID-19 infection is uncommon, is uncommonly symptomatic, and the rate of infection is no greater when the baby is born vaginally versus cesarean, breastfed or not, and allowed to contact the mother. And this should be reassuring that we can, as a matter of fact, in these situations, the baby can be close to the mother. The outcome is not really effective. Let's look now at gynecology services. One of the things that our college here in the UK and the other societies, as a matter of fact, both in Europe and the US, have said that 25% of the care we give in gynecology can be done remotely. And this is not in COVID time only. We think this is going to be in recovery time and for the future. For instance, heavy menstrual bleeding can be managed remotely. And we have to reassure the patient that heavy menstrual bleeding has a negligible risk of being a symptom for cancer. You need to check that the woman is not anemic. The same applies for intermenstrual bleeding, and it's interesting that our college says that if someone has intermenstrual bleeding, you've excluded an infection, talked about contraception, you might actually even try her on a contraceptive pill if it's acceptable and she doesn't have risk factors, just to tidy her over, allow her to have a normal cycle, reduce her anxiety, and then see her when the time is right. Hormone replacement therapy, management of the menopause is done remotely. There is an issue around laparoscopy because it releases aerosol, so the advice is to limit the use of laparoscopy during the COVID, the era. And obviously, if you are admitting someone for elective procedures, they need to isolate for 14 days. This may be reduced to 7 days now, and they need to be tested. We say 3 days, we now can probably test them on the day and get the result quickly. We have to remember that we tell every woman who are look to us for care that we are open 24/7 for emergencies. So acute abdomen, pelvic infection, tubo-ovarian abscess, early pregnancy bleeding, PMB, postmenopausal bleeding, and I put here abortion request. That is seen as an essential service that needs access immediately to care. What are the challenges for sexual reproductive health services? Well, I think first of all, we need to set our standards. So contraceptive care is time critical and therefore needs to be prioritized. So IUDs for emergency contraception, for instance, has to happen. Abortion care is an essential service and therefore has to continue to be provided with no restrictions. Many gynecological problems can be managed remotely, as we've said. Emergencies we've also talked about. And if we have to see time-critical gynecology, we need to see the patients in a green environment away from the COVID centers. And it is perfectly legitimate to see women with severe anxiety as they present, for instance, once you do either a remote consultation video or a phone consultation. I run one of the biggest centers for colposcopy in the world, and it's very important that women who have high-grade cervical disease, cervical intraepithelial neoplasia, who need colposcopy, have access to that as well. Let's look at contraceptive choices. So short-acting reversible contraceptives, mainly the oral products. Emergency contraception can be accessed over the counter, except for IUDs, for which we need to prioritize the patient. As far as combined hormonal contraceptives, i.e. the pill, the patch, or the ring, the Faculty of Sexual Reproductive Health in the UK essentially says that if the patient has had a checkup within the last 6 months, you can actually send her a 12-month supply. And this could be online or what we call click and collect, meaning you you send a prescription to a designated pharmacy and the woman can go to the pharmacy without needing to come into hospital. You need, in order to assess the woman, to probably design a questionnaire which is based on the medical eligibility criteria class 4, which are the absolute contraindications. Remember, you have to assess the risk of pregnancy. That I think is very important. And the things that we do, checks that we do in women using the combined pill, blood pressure, BMI, can be done now, accessed quite easily by the women themselves. The progesterone-only pill is actually the contraceptive for the COVID era because it's ideal for initiation. It is safe. It's easy to take because it's usually an everyday pill, and we can supply 12 months if the patient is already on it. And it is the best bridging method for those who are using any of the other methods, especially the long-acting, where they may need cover. And we will discuss this in a minute. I think one of the things that we need to be aware of is that there is a coagulopathy risk in COVID-19 infections, and something to think about. This is another sort of busy piece. This is a paper published recently in hematology research, thrombosis research, and it looks at the risk of venous thromboembolism. And the point I wanted to raise is that there is a 20% risk of thrombosis and 3% risk of stroke. So in the rare cases requiring ICU care, coagulopathy have been noted. In this published series, 20% for thrombosis and 3% for stroke. We're still learning about this phenomenon. Remember that patients in ICU and actually patients who then leave ICU tend to be weak, they tend to need time to recover, they may continue to have some post-COVID effects, and therefore they could be immobile for a while. And therefore you need to really remember the risk of thrombosis when we are looking at their contraceptive. And I think a good contraceptive history is important, mobilization, hydration is important, but a review of the contraceptive choices would be clinically appropriate. If clinically appropriate for the patient, should be done. Let us look at long-acting reversible contraceptives. The faculty here in the UK, which is part of the Royal College of Obstetricians and Gynecologists, has essentially said that for banded IUDs, i.e. IUDs like the T-Safe 380, we can extend the use for up to 12 years. So if a woman comes, rings you and says, I need to have my IUD changed because it's been there for 10 years, you can say you can use it for another 2 years. If she's anxious or if you're worried about her, you can always bridge her need for contraception with the POP until a time comes when you can see her to replace her IUD. The same applied to Mirena. The faculty says it can be extended to 6 years use and bridge with the POP if required. But you can't extend the use if the Mirena is used for endometrial protection. And here in the UK, we anyway say that if a Mirena fitted in a woman over the age of 45, it can stay to the age of 55. With Nexplanon, with subdermal implant, again, the faculty essentially says that if someone needs change, a replacement at 3 years, she can use her, depend on her implant for another 4 years. And if you're anxious about her or she's anxious, bridge with the POP. This extended use does not apply to non-branded IUDs, for instance, the Nova T380. It does not apply to Jaydes, Kylena, Skyla. For injectables, the same. The success story here in the UK is the use of Cyanopress, where the patient can be taught to self-inject, and that has been a valuable addition. There is a video available which you can Google and search for, and you can therefore do that. But if you need to bridge the period of non-cover with Depo-Provera, for instance, the POP again is the ideal bridging method. For abortion, it's an essential service. Self-referral is appropriate in this time. A remote consultation is possible. Medical termination of pregnancy should be the primary offer, and the tablets could be taken at home. You have to remember to supply contraception, and follow-up for these cases can also be done remotely. I think we need to, in all of this, look after ourselves and keep connected, and we are using one of the technologies. There's Zoom, there's Teams, there's BLUEJEANS, there's Skype. We have been using remote meetings like multidisciplinary team meetings, not only in our specialty, but also to discuss COVID patients who may come to the service. Webinars to spread the knowledge like this one. I think if you're working within a healthcare environment where you're taking referrals from family physicians, from primary care, then you need to be in touch with them to know what their situation is. But there are also now regional and local specialty groups. For instance, on WhatsApp in London, we have the colposcopy WhatsApp group. So we can just text a message to say, what are you doing about this? What do you think about that? Service coordination. And there are now trainers forums as well. If you are a trainer and you're concerned about your trainees, then you can ask for help from colleagues. And of course, remote training and use of skills lab is possible. I think we need to support those of our colleagues who are shielding. They have a risk factor, and therefore they're staying at home. You need to ring them, see how they are, try to cheer them up. But I think we also need to support those who are working. These are two nurses from my colposcopy team, and 2 weeks ago we thought, okay, what do? We'll get some pizza to the office, and I went and got them these chocolate cigars. They're Spanish. They got, I think, cigarella de chocolat or something to that effect, just to support the team and make sure that as they're working very hard, as they're feeling stressed, they have time to have some fun. You need to stay in touch with data and resources, definitely with your suppliers, with the pharma partners, as we are likely to experience shortages in contraceptives, including actually condoms. The world is becoming poorer. Some factories may not be working to full capacity. We may need to know the generic names of pills, and I would encourage you to ask your suppliers to access or get together a global directory of brands of contraception. During the 3-4 months that have passed, some of my patients will ring and say, listen, I get my pills from my family in Budapest or in Bulgaria, and this is my pill, and I now can't get it. I need you to prescribe something similar. So it will be helpful if we have a directory. If you want information about COVID, the Johns Hopkins Resource Center, which are easy to Google, will give you a daily, actually hour by hour update. If you're looking for good slides on mortality, economic impact, the British paper, the Financial Times, has a very good free access to this resource. People have post-traumatic stress disorder, and here in the UK, for instance, Liverpool University provides access. And I just wanted to highlight that in the ESC, we have a COVID-19 resource center. So you check our website, escrh.eu, and we have a lot of documents, many of them the ones that I've just mentioned on the management of gynecology services and on contraception. And we also have a joint statement on sexual reproductive health rights, which is co-written with the Center of Reproductive Rights. I've taken my 25 minutes. So some of these slides I'm going to unfortunately skip. I wanted to take you through a patient journey. I will just show you my clinic. This is our outpatients in London, and you can see the patient walks in, and there is a single sort of directional walking. This is the reception. You can see here the patient stands here at 2 meters and will book, and the spaces between the chairs. You need to also work on the appointment so that you don't have overcrowding. This is our colposcopy clinic waiting area. This is in the old days. You can see we can accommodate 3 here and 3 here and 2 here. And this is now. So our patients will come and can only sit on this chair, and that chair. And we try to actually make the appointments in such a way that we don't have more than 1, maximum 2 patients in the waiting area. As I say, I'm going to skip a couple of things just to talk about the fact that we need to keep in touch with our patients, and that could be online, could be on a telephone, could be on a video consultation. Telemedicine will allow us to send prescriptions or click and collect, as I said. Face-to-face consultations if there is a safe environment. And I think it's very important that if you have young people on your safeguarding database and they have not been in touch with you, you probably should try to get in touch with them. I'm going to leave this slide again. It will be definitely on the ESC website, which looks at the principles of remote consultation. One of the important things is that we have to validate the identity of the patient and establish that she is in an environment that gives her privacy and is confidential. If you suspect intimate partner violence, you need to agree with the woman signs that suggest that she is with her abusive partner and can't speak. So if it's a video, she lifts her hand. If it is a telephone, if she coughs twice, means I cannot talk. And I'd like to thank you very much for listening. I think we need to keep the conversation going. The ESC website now offers a community facility, so please check that. And this is our pitch to invite you to apply for our membership. The membership fee is really good value, 60 euros. This is the address to apply for membership. And for the membership, you will get 6 free editions of the European Journal of Contraception Reproductive Healthcare. You get regular newsletters, access to all the Congress presentations, webcasts, and e-posters. You can register with a reduced fee to the congresses. You can stand for the board and therefore represent your country. And you can access online community forum. This is Doc Matter, which we have just launched. And my last slide is to invite you to the next Congress of the Society in 2021, which is on the 1st to the 4th of September in Ghent, in Belgium. It's going to be a fantastic Congress. We have now re-established it as 3 days. Ghent is a beautiful city. The university there has a big public health department, and therefore we're hoping that the Congress will be more global, so we'd like you to think about that. And Belgium is very easy to get to by car from Europe, so if you're still not very comfortable with flying, definitely you can drive. And I will now hand back to Kai to introduce our next speaker. Thank you very much.
So, can you hear me? So I'm Kai Haldre. You heard my voice. So thank you very much, Ali, for this really nice and comprehensive overview. And I hope we will have a lot of questions. And now I would like to give the screen, not the floor, over to my very good friend and colleague, Teresa Bombas. We know each other 10 years at least, from Portugal, from Coimbra. So yes. The screen is yours. So Teresa will introduce herself, but she has a lot of functions in many societies, and including ESC. So please, Teresa.
Okay, thank you, Kai. I hope everyone is seeing my slides. Are you seeing my slides? Yes.
You have to put the screen.
Yes,
like
this. Okay.
Yeah.
Now you are seeing my slides.
Yes.
It's correct. Sure. So,
yes.
Everything is okay?
Yes.
Okay, thank you, because I'm not seeing anyone. So it's a little strange this new year. In fact, I'm glad to be here, and it's an honor to be present in this first webinar. In fact, one part of our lives in reproductive health are done with the European Society of Contraception, and it's an honor for me and for my country to be here. So I will talk about this new era of progestin-only pill. This is my declaration of interests and our agenda. And as Ali said, in fact, all of us recognize that sexual and reproductive health are essential services, but we live in a real world, and family planning and abortion in the last 2 months was the access was limited, and different countries have different problems. But in fact, the majority of the scientific societies realize that access to family planning and abortion could be a problem, and give alerts for that to keep these essential services. Even European Society of Contraception published a paper about it, and the paper is signed by Mary Short and John Spitzer. And in fact, we have all the fear that this essential service could not be accessed for everyone or open for everyone. In fact, where are we now? Before COVID time, we know that we are a lot of women in the world that are not accessed to contraception, because we live in a world with different images, different laws, different strategies, and now we have COVID time. And COVID time makes the things quite difficult. The travel, the importation of products, the access to appointments, it's difficult. And of course, we must liberate the access, organize appointments by phone, long supplies of contraceptives, and of course, you have to be care of the woman's health, and for that, POP or progestin-only contraceptives could be a good choice. In fact, when we deal with hormone-combined contraception, for healthy women, I think it's very important that it's make this clear, healthy women could use all contraceptive methods. In Portugal, we have 58% of pill users, combined pill users, and the rate of VTA events are quite low. So it's safe for the majority of the women. But when we have to check and about health, and in fact, we have very ill women that in these COVID times have difficult access to sexual and reproductive health services and family planning services. So when you have to switch from the methods, or we have to start the methods, and we have to be careful with this health situation, and we have to respect even in this COVID area, because we have risks enough for our health. We have to be respect for the medical eligibility criteria. I think everyone knows this, and in fact, we have to promote safe choices. We are responsible to maintain the access, and we still are responsible for promote safe choices. And when we look for safe choices, not only the progestin-only pill, but all the progestin contraceptive methods are eligible. I think everyone that works in family planning are familiar with the sentence that the woman come and say, my cardiologist said that I cannot use hormones. Your cardiologist said that you cannot use combined hormonal contraception, but you are eligible for progestin contraceptives in the majority of the cases. So we cannot forget this situation where we cannot use combined hormonal contraception, but we can use progestin contraceptives in a way, or in a safe way. And this is the majority of the disease where we can not use combined hormonal contraception, but we can use progestin-only contraceptives in a safe way. In fact, the contraception have been renewed, a lot of things new becoming to the market, but in the progestin products, we have long-acting methods that now in some countries could be difficult to access, but we stay a long time with that without anything in an oral way for progestin-only contraceptives. In fact, we have some women that are very comfortable with the daily pill, and we need something new on the progestin-only pill. And now we have a new pill with drospirenone. We know drospirenone from combined hormonal contraception, and we have now a new formulation of drospirenone alone. Don't forget that we have as an OTC emergent contraception that is a progestin only and is accessible and eligible for women, all women independent of the health situation. So we need to improve choices. It's very important that we have different choices for different women, that we can individualize choices. And as I said before, we have to improve choices for women who are very comfortable with oral contraception and daily use, for women who are very ecologist and don't want a estrogen combined contraceptive, and for women who cannot use estrogen contraceptive. It means that for women that have severe illness and the risk of the thromboembolic risk are higher. So we have now another option. We have a drospirenone-only pill, and of course we know that from the dosostrel-only pill that the efficacy is comparable to the combined hormonal contraception. We know that they are safe regarding thromboembolic risk, but what we need is, because the big problem with POP is the unscheduled bleeding and the androgenic effects, So we need something new in this field. And you can find all my documents that I will present and on this nice paper published by Professor Santiago Palacios from Spain and a group of researchers that are in the back of this of the research of this new POP. We know drospirenone for a long time is a fourth-generation progestin. We know the properties that are very similar to the natural progestin, and we know that the effect of contraception in hormonal contraceptives is from the progestin, and the estrogen compound are related with cycle control. So these new progestin have the same mechanism of action that the desostrol that we know before we have this POP. And what are new in this POP? In my opinion, we have one thing that is very good that we have also in the desostrol pill. It's the continued use. So the situation that women stop a few days, 4 or 7 days, and start another blister. We know that is in this starting of a new blister that the woman sometimes forgets and they get pregnant. So this is a continuous use, but it's 24 pills with 4 milligrams of drospirenone and 4 pills of placebo. What it means that we have 4 hormone-free days, and we have, in the majority of the case, we could have scheduled bleeding or predictable bleeding. One important thing is because when you look at the papers, we can say, but we have from YAS, and from YAS we have only 3 milligrams of drospirenone, and now we have a higher doses. Of course, we have a higher doses because we don't have estrogen in that pill, and when you look at the concentration, the seroconcentration is lower. But what the studies show us that is lower, but it's enough for block the ovulation. And this is the most important message. It's higher dose of progestin in the pill, but in the blood is lower, but it's enough for contraceptive effect. And when you go back and when we go to the clinic, that was important, very important for us. What about the number of the women that get pregnant with this new pill? Are the same or not the same with these different pills that we have in market? When you look at the studies, and there's 2 big studies with a lot of cycles, 2 European studies done, and in fact, the Pearl index is 0.7. And when you compare the Pearl index of this pill with other pills in the market, are comparable and are the same. So we are talking about the same efficacy. Of course, we have to keep in our mind that the thing that is very important is that COC and POP have the same efficacy, but in contraception it's in our mind always an important fact is that it's perfect use and typical use. We are not living in clinical studies, so we are living in real world with schedules and working at night and working during day. And you have the same POP and COC have the same efficacy, but when you look at daily contraceptives, in fact, they are not the same efficacy than long-acting methods because they are user-dependent methods. So if the woman cannot use a daily pill, POP, independent of the combination of the product that are in the pill, are not eligible for that woman. Another thing that it's important and that it's very comfortable for us is that drospirenone has a half-life of 30 hours. So in a missing pill, it's very important because this interval is higher and the risk of unplanned pregnancies is lower. We have this half-life longer in NOMAC that we have in the composition of Swelly, but in the other progestin is not the case. So for us, of course, for us as a doctor is comfortable, but in my opinion, we cannot say for our woman that you can forget a pill or you can forget it 30 hours, that's no problem. No, it's not true. It's a daily pill you have to take every day, but if you forget, we know that it's okay. We have a march we have an interval of safe. We know from the other progestins that one of the important things for the progestin-only contraceptives is because there's no risk there's no thromboembolic risk. I show on my first slides. In fact, this is the major difference between POP and combined hormonal contraceptives. And the studies show that this new pill of drospirenone, 4 milligrams of drospirenone, have the same safety that we know before from the other progestin-only contraceptives. And in fact, the studies show that the DOP does not influence the hemostatic parameters. And when you look for clinical research and when you look for the studies, and we have 2 European studies, big studies doing in Europe and one doing done in United States, and the studies that are done in United States, the women have a high risk of thromboembolic because they are obese, they have different family stories, and they are older. And when you look the results of all studies, what we expect with this progestin is that there's no thromboembolic events. So this pill is safe as the other pill that we have with the progestin only, and this is so safe as and is as safe as the other progestin that we have in the market. And about bone, we have always this worry about bone when you use a hormonal contraceptive without estrogen. We know that the majority of the progestin only that we have in the market are safe for the bone, implants are safe for the bone, intrauterine device are safe for the bone, desostrel is safe for the bone. We have only problems with Depo-Provera, but we know too these problems are in the early or in the late life. And the majority of the women that use Depo-Provera, there's no clinical risk of fracture, in fact. But here in this combination, because we have 24 pills active and 4 pills with no active medication, so these 4 days, it's sufficient for the levels of estrogen become in the normal range. So the bone is protected with use of these new estrogen pills. So you can use it with safe in women in perimenopause, for example. And one of the things that are important and is quite safe too, and in the woman with mild hypertension. We know that one of the fears could be because the metabolic effects of drospirenone, and what will happen in a woman with a normal blood pressure. And we saw that women with normal blood pressure don't have any change from the baseline of this blood pressure. And one advantage is when we use this pill in the woman with mild blood pressure, the level, the blood pressure decreased and came to normal range. So it's could be important for some women, this therapeutic effect. And what about breastfeeding? We know from our clinical that the one big group of women that start the POP is after delivery. Now we are improving very much the postpartum contraception, and when the women go home after delivery, we make this contraceptive counseling, and we promote the starting of a POP. And now, because it's drospirenone, what could be the impact in the quality of milk of these women? And the studies show us that the quantity of drospirenone that goes in the milk, in the mother's milk, is very little and completely safe, and the quantity of the milk that is produced by the mother is quite normal. So there's DOP don't have any impact in breastfeeding, so it's quite safe for the women that are in breastfeeding. One important thing, and we don't like, not we, but women don't like from the progestin-only contraceptives, is the unscheduled bleeding. The women, in my experience, they accept very well that are in amenorrhea, no bleeding. They accept that they have scheduled bleeding, like we have in combined hormonal contraception, oral, vaginal, or patch. But the women don't like to have unscheduled bleeding, and they hate it if the bleeding is too heavy. We have this problem for some women with the POP that we have in market, but with this 4 milligrams of drospirenone, with this schedule of 24 active pills and 4 placebo pills, what we see is the majority of the women have a scheduled bleeding, what is quite good, and is a good difference between the drospirenone and between the desostrel and this new pill. The majority of the women have scheduled bleeding in the first cycle, and the majority of them maintain scheduled bleeding. And when we compare the bleeding profile of desostrel and this new drospirenone pill, what we see in the first cycles, the number of the women that have prolonged bleeding, that is something that women don't like. It's less in the users of drospirenone and becomes less with the time of use. So it's less in the first cycles. That it's one problem with desostrel pill and with progestin contraceptives, and tends to be less with this drospirenone pill. What is a big advantage? And what about, we have already discussed the bleeding, and when you check the number of the women that stop the pill because adverse events, we see when we compare the group of drospirenone and the group of desostrel that the bleeding disorders, the stop the contraceptive for bleeding disorders are higher in the group of desostrel. And another problem that we have with the progestin only contraceptive is the androgenic effects. And we are glad here because we have anti-androgenic progestin here, and it's quite comfortable. And the number of the women that stop to use this pill because androgenic effects are lower in the group of drospirenone when you compare with the group of desostrel. Another important thing is more important for the women than for the doctors, because we know from long time that the hormone contraceptives are quite comfortable for the body weight, but is the first question that everyone, every woman asking when they are counseling about contraception is, what about age? Then never forget, they always forget that age, no exercise, and the food makes you stay fat, but they always go with the responsibility to the contraceptive method. But in fact, it's important that when you compare the drospirenone group and desostrel group in the woman with normal weight, and there's no difference. And when you use these in women obese, the difference are not significant. So it's very important. I didn't show here the results, but even in obese women, we know from the other contraceptive methods, and there's a study here regarding the use of drospirenone too, that this only contraceptive pill is effective in obese women as effective in a normal weight woman. So what we have lower expose of drospirenone, but without compromising the efficacy. We have a safe regarding thromboembolic events. So this new pill is eligible for women who are ill or have risk or have thromboembolic risk, or even for women who don't want combine a contraceptive, or for women with have adverse effects relating with estrogen. So it's quite safe. It's important that the blood pressure stays stable in the woman with normal blood pressure, and it could have a therapeutic effect in the woman with mild blood pressure. We don't have any negative effect on bone. It's safe during the breastfeeding, and the bleeding profile looks better than the bleeding profile with desostrel. So the number of days of scheduled bleeding is higher, and the number of the women with unscheduled bleeding are lower, and the number of women with prolonged unscheduled bleeding are lower. So this is my message. Thank you everyone for keep with us and keep safe. And Ali has already invited you to come to ESC and to the next Congress. Thank you very much.
So, thank you so much, Teresa. Yes. Can you hear me? Yeah.
Yes, yes.
Yeah. So thank you, Teresa, for this excellent presentation. And Ali is also back there. So I can see now that we have quite some questions, and I can see also that we have a global coverage, which is great. We have Argentina, Philippines, Georgia, France, Turkey, and many other countries. So it's really impressive. So we have exceeded a little bit our time, but I think it was really interesting to listen to both presenters. And I will now move on to questions. Okay. So just some questions to Ali. And a couple of questions have come here about the fear. Like how we can remove the fear of corona. And the other one is how they are able to fight with fear alone. Are they able to fight with fear alone without any support? And if yes, what strategy they applied? So basically fear of corona and how to, because some people are really very stressed, and I think medical people, even they have a better life or easier life. So Ali, how do you address the fear of corona in these times?
Well, thank you. I mean, I'm a very sort of anxious person, so I'm always afraid of things happening to me. But I think actually it's the same situation where you have a patient who is fearful of, for instance, cancer or other medical conditions. I think the important thing is that they have a plan. And I think the public health messages are meant to reassure people that if they follow these public health messages, they will do well, they will be protected. We didn't mention, for instance, the wearing of masks. If everybody wears masks, then the likelihood of the spread of the virus is much lower. I think we need to reassure them that when they come to us in the clinic or in the hospital, that we have all the facilities to keep them safe. And this is what I talk about with a green environment, meaning that they will see that there is social distancing. They will see that we're protecting ourselves, but also trying to protect them. And I think that tends to also help. A lot of patients we see for contraception are young patients, and we know that the impact of COVID on the young is less than it is on the older population. And I think that also needs to be emphasized to the patients. I think we just need to keep the discussion going with our patients to make them feel confident to come to our service. One of the problems we've had is patients who ring our telephone line and say, listen, I'm too afraid to come to the hospital. In these cases, let us offer them a telephone consultation or a video consultation. And sometimes you can, as a matter of fact, say, okay, this is what I would ask you to do now, and perhaps we can touch base again in 4 or 6 weeks from now and then see you. So I think it's just measures of managing patient anxiety.
Okay, so thank you very much. I hope it gave a kind of quick answer to this question. It's my pleasure to see that our very good friend and collaborator, Mario Festin, is also online and has sent you also a question. So Mario, many greetings from all over the world. And Mario says, greetings from Manila, Philippines. Thank you, Dr. Ali Kubba, for the very practical lecture. I have a question. Do you screen your patients when they come to your clinic, such as checking their temperature and their symptoms? Do you need to take a COVID test? Thanks and best regards, Mario. So this is again to Ali. And
okay, well, it was actually in the slide that I did not show, which was a busy slide.
So we can now talk about it.
So what we tend to say is we screen people before they come. So if we give an appointment to the patient, we will send a sheet of information which says, have you been traveling for the past 14 days? Do you have a temperature? Do you have a loss of smell or taste? In gynecology, we've also included whether they have diarrhea, because we know that there is shedding of the virus from the bowel. And because we are working in that area of proximity, we ask them not to come with a accompanying person, because we can only let one person in. We ask them to have evidence that they have an appointment, because we have screeners at the entrance of the hospital. And if someone says, I've got an appointment, and they don't know, it will just prolong the whole exercise. When they arrive, we check their temperature. So we check with temperature. We don't actually do tests as such, and we space them 2 meters. I mean, the 2 meters is likely to become 1 meter because we wear masks and they wear masks. We give them a mask. We offer them a mask when they walk into the hospital, and we have the whole of the hospital, the corridors have sanitizers. So Mario, you should know the answer to this question more than I do, being a WHO man. But I'm delighted you are with us on this meeting.
Thank you, Ali. But I think that, yes, exactly. Since we are international group here, I would like to ask Teresa the same thing. How is it in outpatient departments, and is it different if somebody has to go to the hospital to be hospitalized?
Here in Portugal, we have 2 different schedules, and I want to discuss here, because we are in the international meeting, the access to abortion. Because in these COVID areas, these COVID times, there's some hospital that blocks the access to abortion, And you know what's happened is that the people in another hospitals, the appointments are with more people, and the people have to travel to go to the abortion. So in abortion, we have part of our consultations are planned and organized, but part of them are not organized and the people appear. So what we do, we are trying to organize by times, social distance, temperature, and we promote medical abortion at home. And what we've done is discuss the waiting period. You know, this discussion about waiting period, because we have waiting period in the majority of the European countries. There's only one country where the government stay with the providers and with the woman and keeps the waiting period. But in the majority of the countries, the people and the doctors and the women stay by themselves and organize according to the reality, these waiting periods. And in Portugal, it's the same situation. So we have to organize and mobilize ourselves. And in fact, we make this questionnaire, but we only screen people for invasive procedures or for labor or for surgery or for to stay in the hospital by medical situation. But what is important is we cannot forget one thing. We are very far away, and the rate of maternal mortality are so low in the majority of the countries. But now with this new era, the people don't come, and we are already with problems in the maternal, in the obstetric field that we are not having. We have having people with disease because they are not well treated or well attended during the pregnancy, and they have already came to the emergency service in more negative situation than 1 year ago.
Thank you, Teresa. I can just add that I come from a very small country, 1.3 million, maybe even 1 million living here. And there was fortunately very low COVID pandemic rate, so to say, because people don't hug each other and they keep distance anyway. But in our case, it is we have 69 deaths until now, so in the whole country, and a lot of tests done. So in our case, we have the same as it was described. If you enter a medical institution, then you have to put the mask, disinfect, and the temperature is measured. This is in outpatient care. And then you have also, like, you cannot sit very close to the other one, and as many consultations online as possible. Yes. The other situation is if somebody has to be admitted to the hospital, then, and I work with infertility patients, including there, if we have pickup, then everybody, both the man and the woman, they have to do COVID test. And this is 48 hours before the procedure. So, and those who come to deliver, they have these fast tests, which show a little quicker. So in a way, this has kept the rate low, and this June is promising, but of course we are all aware and we are all waiting for the second wave, and we really have to remain very alert. And this is actually the reason why we organize this kind of webinar in this kind of late stage, because we shouldn't, we are all fed up of it, I can understand, but we shouldn't lose our awareness about it. So two kind of practical questions. Somebody is asking that is it possible to receive the slides? As I told you already in the beginning, this webinar will be open in both ESC and Exeltis web site for 1 month, and it is possible to see the slides. And then another suggestion was about male issues. So this we will take in ESC account, and maybe one webinar about male issues. So then we have some questions also. We cannot answer, unfortunately, everything, but we have a question here for Teresa. So this is just a second. So somebody is asking that since the half-life of drospirenol, a new pill, is 30 to 36 hours and intake is usually 24 hours, is there any data about accumulation, such as in fat tissue? So Teresa, do you have any information or any data about
we don't have any information about that, but could be a question, of course, but there's no specific data about that. We have only data about how to deal with missing pill, but not with accumulation, because in fact the level of drospirenol in circulation is lower than we have with combined hormonal contraceptive with the drospirenol, imagine DIAS, and it's lower, but we don't have specific data about that, as far as I know.
Yeah. Now, another very important question: when can we start the pill after the delivery, postpartum? When can it be started?
We can start, of course, it depends of the breastfeeding and it depends of the wishes of the woman. In Portugal, because we are very usual with hormonal contraception, our message is start after the delivery. When you go home, you can start. Because the majority of the women don't stay breastfeeding for so long. So we said we can start, but in fact, it depends if you go into breastfeeding or not breastfeeding, how long you will breastfeeding, the interval between breastfeeding, it depends of the situation. But in fact, there's no thromboembolic risk, so you don't need to wait this thromboembolic risk after delivery. 21 days you can, like in normal situations, but you can start immediately.
Then another important question is the drospirenol only also safe in adolescents?
Yes, there's a nice study that and is published in the paper that the data are published in the paper that I show published by Professor Palacios. There's a few numbers about a group of adolescents. In fact, in the majority of the situation, the adolescents are not included in the studies, but in this field is included. And what is important, the impact in dysmenorrhea is good. They have less dysmenorrhea. The number of painkillers that they need to use for dysmenorrhea decrease, and the bleeding profile is the same that in the more older woman. And the second thing is that they don't have a lot of problem with androgenic signs because it's drospirenol.
Kai,
yeah.
Kai, can I just make a comment about the postpartum contraception, because
Yes.
it's also in one of the slides that I didn't show. I
Yes.
think as we have a problem with access to services now, and we may have problems to access to contraceptives, post-placental contraception is very important to consider. So in the UK, our faculty has actually said that the progesterone-only pill, any progesterone-only pill, can actually be given sort of immediate, as Teresa was saying, immediately after birth, before the woman leaves the hospital. But there is also an opportunity to fit an IUD or a Mirena or give an implant while the woman is still in the hospital post her labor. If she's having a cesarean section, put an IUD or a Mirena into the uterus. And I think that would mean that people are protected for a long period of time. There is, you solve the problem of access to contraception in the immediate future. So it's something that really we need to think about as a part of our service.
I want just to share with experience that we have, because for these long-acting methods, immediately after delivery, we have to make this counseling during the pregnancy. the last appointments of pregnancy, is very important that we teach and promote the use of long-acting methods. Otherwise, it's not in the time of delivery that you will discuss this with women. If you are thinking about it and you have a chance of do it, you have to use the prenatal appointments to discuss this with the woman or with the couple.
Thank you. This is a very important point. I think this counseling is actually the key in all of what we are saying today. So there is one more question to Teresa. Actually, there are several ones. I'm just taking in the row. So the literature on progestin-only pills claims that ovulation occurs in 40 to 50% of cases. Do we have any data on drospirenone?
Yes, there's a phase 2 studies that they show that the levels of hormones and the size of ovocytos, everything is shown. You can find these results if you find you can, because these results are published, and they show that in the majority of the cases there's the effect of the contraceptive effect is the block of the ovulation. The majority of effect is the block of the ovulation, and is the same with desostrel. We don't have I remember it's for my beginning time of gynecologist that we have a different pill that it's Exeltis. I think no one uses this anymore. And in that fact, this pill, the contraceptive effect is not related with ovulation, but is related with cervical mucus. And this generation of progestin are not like that. The major effect on contraception is block the ovulation. So it's the same for desostrel and as for drospirenone. And this is demonstrated. It's published.
Thank you. So last, we have really a lot of questions, but I think we are already half an hour over our planned timing. So the last one to Ali. This is when you, just one clarification, when you say COVID test, do you mean rapid test or PCR?
Well, we are using a swab test when we check patients who are coming for a planned event, where antibody testing is being used in the UK for healthcare providers. So I've had mine, so I know I'm negative, unfortunately. So if we get a second peak, I have to be very careful.
Yeah, but I think there are two tests also, PCR, which is one is quicker and the other takes a little bit time.
Yes.
So we use the quicker test. Yeah.
In how many hours?
Well, it depends. I don't know what our lab does, but we can get the result within the day that the patient is in.
Okay, I can give a help. We have different tests here in Portugal in different hospitals, and we organize like that. When you need a fast one, you use PCR test, and we have the results in 3 or 4 hours. But when you have an elective procedure, we use a different test, and the results came in 24 hours. So we have to organize according to the assess to the patients what is better to do. But in a delivery, for example, we use rapid tests.
Yeah, I have to say that we have the same in Estonia, that in delivery it's rapid test, or if we are in a hurry, but if there is time, then we do it the day before or 2 days before. Because
in the beginning was terrible, because we don't have this rapid test, and the test takes a lot of hours, and the baby born before the test is already finished, and we have the results, and we have to put the mother in one place and the baby in another. It was completely mess.
And personnel in quarantine because there were not enough equipment in the beginning. Yes. So, but we have learned a lot. We have learned a lot. So
yes,
I really have to stop here. There are so many interesting questions. I feel pity about it, but rien à faire, nothing we can do about it. We will try to answer all these questions in written. And I will, yeah, so I thank everybody who has sent these questions. So, and you will find the information on our web page, I mean the webinar itself. But here I would like to have a couple of closing remarks. So can I have my conclusion slide, please? Philip? Is Philip there?
Oh,
yes,
yeah.
very good. It starts to work. So still, I'm not Peter Erhard. I'm Kai Haldre from Estonia, and I'm happy that everything works. And I'm happy that we were so enthusiastic to be here more than an hour, actually 1.5 hours. So just repeating is the key. So the conclusions from today you can see here from our two presentations, just to repeat once again. So about COVID, we learned today that pregnancy does not increase vulnerability, and we learned that the third trimester is a risky period, but in general, babies do well. So we also learned as medical specialists and countries that many gynecological conditions can be managed remotely, and it has become now new normal. It will most probably stay, and we really learned a lot about it. And then we also were reminded that, and what we have to remind to our governments and managers, that contraception is a time-critical intervention, and abortion services are everywhere essential. This is very emergency care. Then we have learned that extended usage of LARCs allows us to control the demand and to match also with the available capacity. Progestin-only pill is a very good breaching contraceptive. It's very safe, and it has to be available everywhere without any barriers, as few barriers as possible. It is safe. And providing post-placental contraception is a very good option for women and also very good for the healthcare system. From Teresa's talk, what we have learned, it is about the drospirenone-only pill. And we know now that it has lower systemic exposure without compromising its contraceptive efficacy. There was a study which results we were shown that there have been no thromboembolic events in the more than 20,000 cycles which were tested. It has neutral effects on blood pressure in normotensive women and positive effect in women with mild hypertension. Then we know also that mean estradiol levels are with this pill within the bone sparing effect range. So no bad effect on the bones. We know that this pill is very good after delivery. It's safe for breastfeeding women. And these studies, what have been done so far, have shown that there might be, or there is, a better bleeding profile versus the other molecule called desogestrel. So this is the repetition from today. Can I have the next slide, please? Philip, can I have the next slide? Yes. So I really want to remind you that we have other educational events. So here is our today's webinar. We hope to continue in September, so please keep eye on our website. This is just, oh, no, not yet. Then there will be in April next year in Belgrade, there will be our course, very good 2-day course about the modern contraception, very detailed, so please register. And now our main event next year. So Philip, the next slide, please. Yeah, the next slide. So as it was mentioned already, but I would like really to highlight it once again, we will have a very good Congress next September in the beginning, 2021, 1st to 4th September. And the program, we have been working with it for several months, and it will be really very holistic about all kinds of aspects of sexual and reproductive health, about sexuality, about education, about global attitudes, about public health. So there will be really a very, very holistic approach. So welcome everybody to our Congress next year. And once again, the last slide, please. just a reminder. So as Teresa and Ali already showed, those who became very enthusiastic now and are still not yet members, please become, here is information. You have to go just on our webpage and become the member, and you will enjoy all the benefits. And we will meet with you very soon, not online, but in real life. So we have come to the end. It's almost 1 hour and 40 minutes, but here I really like to thank all the participants, and it seems really all over the globe. I saw now India has sent an email, and so many countries, Philippines and South America. So I really thank you for joining us today. I would like to thank Exeltis for this unrestricted grant to our society, European Society of Contraception and Reproductive Health. And actually, as Teresa has finished her presentation, please stay safe and please stay with us in the future. So see you soon.
Yes, thank you.
Bye.
Bye.